I'm honored to introduce our first speaker, rheumatologist John Reveille, MD, who'll be presenting Medical Management of Spondyloarthritis in a Changing World. Dr. Reveille is Professor of Medicine in the Division of Rheumatology and Vice Chairman of the Department of Medicine at the University of Texas Health Science Center at Houston. He served as Director of the Division of Rheumatology from 2002 to 2019. He is a prolific researcher, having authored countless publications and playing a vital role in many clinical trials and other studies. Dr. Reveille received his rheumatology training at Johns Hopkins University. After fellowship, he was assistant professor at the University of Alabama at Birmingham, before being recruited to join the faculty at the University of Texas Health Science Center at Houston. He was promoted to associate professor 3 years later and became professor in 1997. Dr. Reveille has dedicated much of his career to studying and researching spondyloarthritis and working to improve the lives of those living with it. Dr. Reveille has received the Outstanding Achievement Award from SAA in 2003. He is a long-standing member of our medical board, and we continue to rely on him for his leadership and assistance in many medical and scientific matters. We are just so grateful to have you with us, Dr. Reveille. Dr. Reveille was a past director of the North American Spondylitis Consortium, and he has also served as the principal investigator of the NIH-funded program on the genetics of spondyloarthritis. He is a co-founder and member of the executive committee of the Spondyloarthritis Research and Treatment Network, or SPARTAN, and was selected as a Master of the American College of Rheumatology in 2019. He has served as the director of the HIV Rheumatology Clinic at the Thomas Street Clinic since 1991, and he was also president of the Pan American League of Associations of Rheumatology, also known as PAMLAR. Okay, and without any further ado, welcome, Dr. Reveille.
We'll start with the spectrum of spondyloarthritis. The current concept, it's divided into two worlds: the world of axial spondyloarthritis, and which ankylosing spondylitis is part of that larger circle. Then we have peripheral spondyloarthritis, and that includes psoriatic arthritis, the arthritis of inflammatory bowel disease, reactive arthritis, and if someone doesn't fit well into one of those categories, they're just called undifferentiated peripheral spondyloarthritis. Ankylosing spondylitis is probably the hallmark of this, and much of what I'm going to say has really been done, it represents work done in patients with ankylosing spondylitis. So first of all, let's start with some prevalence numbers. Chronic low back pain occurs in nearly 1 out of 5 people in the United States between the ages of 20 and 70. This was in the National Health and Nutrition Survey 2009-2010. And if we look at the age of onset, it's interesting, a large number of these people actually have age of onset relatively early in life. Okay, so this is a big, big problem. Then we have the idea of chronic inflammatory back pain. There's different criteria sets out there, but they share commonalities at young age and onset. Okay, it's a chronic disease. It occurs gradually, insidious onset, associated with morning stiffness, improvement with exercise, but not with rest, awakening the second half of the night, and least common, but most specific, alternating body pain. Again, these are the criteria that are out there. And of course, inflammatory back pain is part of the spectrum of axial spondyloarthritis, which I've already shown you is the big circle in which ankylosing spondylitis is contained. Because it takes, on the average, between 7 to 10 years from the onset of the inflammatory back pain until the x-rays actually turn positive and you meet criteria for ankylosing spondylitis. So we start with sacroiliitis and MRI, progressing to radiographic or standard x-ray, sacroiliitis, to finally the bones, the typical spurs associated with ankylosing spondylitis called syndesmophytes, all happening over time. And that's, of course, the modified New York criteria. We know that the overall prevalence of ankylosing spondylitis is somewhere between about 0.57%. This was shown off of 2 different NHANES surveys, 1971 to 75, and again, 2009, 2010. But if we look at axial spondyloarthritis, it's quite a bit more common. Depending on whose criteria you use, it ranges between 0.9% and 1.4%. And although ankylosing spondylitis is more frequent in men, but actually there's a slight tendency towards women to be more commonly affected with axial spondyloarthritis. The prevalence of inflammatory back pain is 1/3 of the prevalence of chronic back pain. 1/3 of the people with chronic back pain have inflammatory back pain. And I've already mentioned about the frequency of chronic back pain in a previous slide. And of course, most recently, we've been using for classification the so-called OSIS criteria, which we'll use for axial spondyloarthritis, which has either sacral imaging, whether it be standard X-rays or with MRI, or being HLA-B27 positive. Here you have to have 2 of these features. If you have the imaging positive, just one of those features to meet OSIS criteria for axial spondyloarthritis. They perform pretty well. We're in the process of reevaluating them in what's called the classic study in the United States to see if we might improve that sensitivity and specificity. Now the issue is that if we look at people with axial spondyloarthritis and whether they go on to progress ankylosing spondylitis, we see that even after 10 years of disease, somewhere between 60 and 40% of people are still having axial spondyloarthritis, especially women. They're more likely to never progress to having radiographic sacroiliitis, yet we know already that they have the same burden of disease, the same impact on functionality, and the same pain levels. So first of all, what is the cause of AS? We know that HLA-B27 is very, very important, onto which other genes, as well as environmental factors, we're going to talk about infections, toxins, biomechanical forces, trigger inflammation that ultimately gives rise to new bone formation. I'll talk more about that later. As far as the genetics of AS is concerned, that I've already talked about the prevalence of B27 in Caucasians. 90% of AS patients are B27 positive, but less than 5% of people who are B27 positive ever develop AS. Although if you have a first-degree relative, mother, father, son, daughter, a brother, sister, your chance of getting AS is somewhere about 1 in 5. So if you have a family member that's affected, your chance of having spondyloarthritis goes way up. That as far as causation goes, that B27 forms about 40% of the overall risk. That identical twins are much more likely to have the share AS, if one has it, the other has it, as opposed to non-identical twins or fraternal twins. So the question is, what does B27 do to predispose to AS? Well, what these HLA-A, B, and C molecules are supposed to do is they bind a little piece of protein called a peptide, and they present those to lymphocytes. And that's what they do, and they trigger an immune response, okay? And we've been looking for this antigenic peptide for years. We've yet to find one. Another thing that B27 molecules do while they're inside the cell is that they tend to not fold right, and they sort of clog up inside the cells and cause sort of like when a toilet clogs up. It gives rise to something bad, in this case, an unfolded protein response. It can also stick together and come out to the cell surface as what's called a homodimer, where 2 B27 molecules are stuck to each other. And they get recognized by different kinds of white cells called natural killer cells, and give rise to a whole bunch of other immune responsive. We know that, and I'm going to talk quite a bit about this later, that patients who are B27 positive are unable to deal with certain bacteria inside cells like salmonella and chlamydia, and that raising the concern whether infection or immune response against that infection acts as a trigger. And finally, we know that people who are B27 positive have a different microbiome, and the changes in the microbiome perhaps predispose to AS. Well, dealing with some of the other genetics, this is a paper we published last year. We HLA typed 1,946 Caucasians, white people, 67 Black people, and 446 Han Chinese. So a fairly good number of patients. We looked at all the HLA types, B types associated with it. We found, of course, that B27 was present. That's the Chinese B27, by the way. It's B2704. That's going to be highly associated with AS in Chinese. In whites, we find the most common white B27 subtype and the second most common. In blacks, we found mainly the real common B27 subtype. But, and there's another protein, allele called B40, that we found to be associated in whites, in Han Chinese, and in blacks. And other B proteins like B35, B15, and B7 are actually negatively associated to disease. So if you have one of these, you're less likely to develop ankylosing spondylitis. HLA-B is located in the most important part, I think, in the genome, to me at least. There's HLA-B right there. That's HLA-B gene. This is the major histocompatibility complex. 220 genes in there. We're only showing the most prominent of them right there. Other genes, like there's your tumor necrosis factor genes, and you're those taking tumor necrosis factor blockers. Well, you know where that protein comes from. And there's HLA-A, HLA-B, HLA-C. Here we have HLA-DR, DQ, DP. Okay, so this is all the major histocompatibility complex here. A lot of genes, very, very important in the immune response. Okay, and so we looked at those other genes, those other major histocompatibility genes, and we looked at overall, found a whole bunch of them were associated with AS, but including some negative association with one called DR15 in the HLA-DR region and DP0301. We found those to be positive. That was positively associated. This was negatively associated. I'll revisit that. Then we looked in, since we had 1,948 white patients, we figure since 10 to 15% are going to be B27 negative, and that the work in this area has been complicated by the fact that no one had a series large enough to really study B27 negative AS. We found the same associations. Most of those other associations I talked about washed out. They washed out because they really are just genes that sit next to B27, and they themselves aren't doing anything. But certainly negative association with DR15 and then positive association with HLA-DP0301 remained there even in the B27 negative. So we knew that these were playing an important role. Of course, there's a lot more genes that are going on. We now know there are up to 133 genes that are associated with AS. I'll get to that in a second. Genes important in IL-17 mediated immunity. And of course, those of you on Cosentyx or Taltz know that that's an IL-17 blocker. That's obviously going to be very important. In white blood cell functioning, that's a certain kind of white blood cell called CD8. In presenting proteins, I talked about earlier, genes that are important in that. Genes that are very important in sensing those germs that are in and on you, and a bunch of other genes that are very important in the immune response. So what's interesting, however, is that ankylosing spondylitis represents a network of genes that is shared by psoriasis. That's the green circle. AS is the dark purple circle. We have the blue circle, the genes associated with Crohn's disease, and then the orange circle, that of ulcerative colitis. And what we see here is that there's extensive sharing of genes with AS and Crohn's disease and ulcerative colitis and psoriasis. I'll show that more a little bit later. So, and we certainly see that in both patients with AS as well as in their family members, that there's a much higher frequency of psoriasis, ulcerative colitis, and Crohn's disease. Another problem we see in patients with AS is, of course, iritis, and this is some work that has just been published. We looked at HLA alleles, and again, we found, if we looked at, just like we saw when we looked at HLA, at AS in general, whole bunch of HLA genes that are associated with uveitis in AS. But if we then controlled for the presence of B27, if we remove the effect of B27, these are the only ones that were left. And this is interesting because there's your DP0301 right there. That's even there. We did ours by direct HLA typing. This is done by a process called imputation. And this was looking at many, many, many thousands of patients, okay? And B7, negatively associated with AS, positively associated with uveitis. DP301, positively associated with both. DR15, negatively associated with ankylosing spondylitis, positively associated with uveitis. So if you do have AS and you have one of these genes, your risk of uveitis is significantly elevated. And if you then control for the presence of DR15, only that DP gene shows up. We were the first to actually show this. It's now been confirmed by Dr. Brown's group. So there are other genes besides B27 that sit next to B27 are also very important, although clearly not as important as B27, nevertheless, in further heightening the risk for this disease. Okay, we're looking at one of these so-called Manhattan plots again. And here we're comparing patients with AS who have uveitis compared to patients with AS who don't have uveitis. And what we find are along with a lot of the regular genes, we see some special genes that are not associated with AS are heightening the risk for uveitis. So it's very clear that patients who have AS, who have uveitis, have additional genes that are in play that are further predisposing to develop uveitis or iritis if they have AS. This is very interesting. This literally just came out in June. Okay, so I'd like to move on to another issue. I'll pause a second. I'd like to move on to another issue. The way we decide how bad the AS affecting the spine is that we score each vertebrae. It's called the Modified Stoke Ankylosing Spondylitis Spinal Score. And we sort of score to see where we see these bridges of bone called syndesmophytes that are present there. And so this allows us to quantitate how much X-ray involvement that we actually have going on here. So we did that, and we looked at how bad the X-rays were. We looked at 1,500 cases, and we found two genes really stuck out. One that's called the rank receptor, another one called cyclooxygenase 1. Rank receptor, of course, we know is, I'll say that again, two genes came out in these patients that were associated with radiographic severity in AS. The rank receptor and cyclooxygenase 1. So they're very interesting because the rank receptor, of course, is one of the genes that predisposes you to get osteoporosis. It's a very important in bone metabolism, okay, as we can see here. And cyclooxygenase 1 is very important in the inflammatory response. It's the target of non-steroidal anti-inflammatory drugs. And we already know that non-steroidal anti-inflammatory drugs can slow down radiographic progression in patients with AS. But there was no association of whether you were B27 positive or not and how bad the X-rays looked or how bad the disease was as far as fusing the spine was concerned, which was very interesting. So the B27 negatives, in other words, have as bad disease as the B27 positives. So let's talk a little bit about psoriasis. I've already mentioned to you that's in the spectrum of spondyloarthritis. And we know that men and female psoriatic arthritis, the arthritis associated with psoriasis, that men and women are equally affected. That psoriasis occurs in about 2 to 3% of the population, and somewhere between 6 and 39%, probably overall between 10 and 25% of patients with psoriasis will have arthritis. Okay, in a big European survey, it was 30%. In a big U.S. survey by the National Psoriasis Foundation, it was 11% of those with psoriasis had arthritis. Usually, psoriasis comes on before the arthritis, and that the severity of the psoriasis, if you have just a patch of your elbow or looking like that, is not predictive of the severity of psoriatic arthritis, but is correlated with the occurrence of psoriasis, and that obesity is a risk factor for the development of psoriasis. So this is a study that we published back 5 years ago, and we looked at the NHANES 2009-2010 survey. We looked at the people in NHANES, 153 people out of the 5,103 people that we examined. We looked at them, at those that had psoriasis compared to those who didn't have psoriasis. Okay? What we found was people with psoriasis were much more likely to have inflammatory back pain, 17% versus 5.4%. They were much more likely to have a previous diagnosis of arthritis, 31.6% versus 18.8%. They were much more likely to meet criteria for axial spondyloarthritis, 14.3% versus 1.5%. Very significant differences. They're more likely to have anterior hip pain. They were more likely to have heel pain. So people with psoriasis are definitely falling very heavily into the spectrum of spondyloarthritis. Indeed, if we look at people with psoriatic arthritis, 40% of a positive family history, that the psoriasis usually precedes the arthritis, and that there are HLA genes that are heavily associated with psoriatic arthritis, B8, B27, B38. And there's, interestingly enough, the gene that's been most heavily associated, the number one, sort of the B27 of psoriasis is HLA C6, okay? C6. And that is the gene that gives about 40% of the overall risk for psoriasis. But guess what? In patients with psoriatic arthritis, there is a negative association that patients who have psoriasis and have psoriatic arthritis are less likely to have CW6, that the male, female, unlike in NAS, where men are more commonly affected, although in axial spondyloarthritis, women are slightly more commonly affected, but that the male-female ratio is approximately 1-to-1, and that there are also environmental triggers in place, such as trauma, infection, and stress. And hopefully I'll give infection. I'm not going to say too much more about this, except to say that streptococcal infection has been the one that's most consistently implicated in that regard. And that we see that there is heavy, that we see here, this is looking at psoriatic arthritis and ankylosing spondylitis and psoriasis. And we see that there's heavy overlap of the genes. There's some genes that are most specific for psoriatic arthritis, other genes that are most specific for psoriasis, and genes that are specific for ankylosing spondylitis. And then we see there's very significant overlap in these categories. So again, these are diseases that are networked with each other. And let's see. So I see one slide though, that basically says the extent to which trauma may trigger this, but apparently got deleted. Okay, moving on to the gut. Over half the patients with AS will have subclinical gut inflammation on ileocolonoscopy, especially in the femoral ileum, which is the part of the small intestine that joins onto the colon. We know very well that there's a development of reactive arthritis following enteric infections, such as Salmonella and Shigella, that these B27 transgenic rats, where the human B27 is introduced into the rat, we know that in a germ-free or antibiotic environment, that these rats don't develop their disease. And that patients with AS exhibit an altered or dysbiotic abnormal gut microbiome. Now, you have approximately 2.5 pounds of bacteria inside of you and on your skin and in your throat, okay? These bacteria are very important. Bacteria that are in your large intestine, for example, are important in you dealing with indigestible carbohydrates you can't digest. These bugs will break down with their bacterial enzymes to form simple carbohydrates that can be used as nutrients or energy. That the synthesis of vitamin K and most water-soluble B vitamins is done mainly by specific bacteria called bifidobacteria and lactobacilli, like you get in your acidophilus. And these are vital nutrients in biochemical reactions. The dietary fibers are broken down by anaerobic intestinal microbiota into short chain fatty acids like acetate, propionate, and butyrate. And these then can generate energy or substrates for building blocks in nutrition, or function as signaling molecules in various tissues for a variety of very important bodily functions. That with a healthy microbiome, you have a nice balance between the so-called good bacteria, like the green ones you hear, and the bad bacteria, like you're looking at those brown squiggly things there. That's the intestinal lining. That's the area inside the intestines, okay? You combine that with genes in the human genome, you get a nice balance in certain inflammatory profiles, the so-called Th17 profile, and the T regulatory profile that gives is associated with health. What if you get dysbiosis? Either dysbiosis that are caused by increased pro-inflammatory bacteria, see all the brown squiggles there, lots and lots and lots of them, that are crowding out the good bacteria. You then will have an interaction with the host genome, and you'll get an imbalance of the T regulatory cells that are outweighed by these CH17 white blood cells and get disease. Or you can get dysbiosis coming from decreased anti-inflammatory bacteria, such as those people who are chronically taking antibiotics, and you get the same effect, an imbalance between the inflammatory white blood cell response and the regulatory white blood cell response, giving rise to disease. And how might the gut microbiota drive spondyloarthritis? Well, as I've already mentioned, there's effects on immune homeostasis, effector versus regulatory T cells. Molecular mimicry, where proteins in the bacteria get mixed up with proteins inside of you that are part of your makeup, and the immune response gets triggered by that. The fact that these bacteria can actually get through the barrier of the intestinal lining and actually get into the bloodstream, or travel to other parts of the body like the joints or the spine. These are all issues where the gut microbiota, the bacteria in the gut, can actually drive spondyloarthritis. And a number of groups have actually studied this. Costello et al., Scher et al., Costello in Australia, Scher et al. In New York, and Dr. Ciccia, who is now in Naples, he was in Palermo, Dr. Reveille in Paris, Dr. Stoll at the University of Alabama, Birmingham, Dr. Manasson, all of whom have shown that there is intestinal dysbiosis in AS, a decreased bacterial diversity characterizes the altered gut microbiota in patients with psoriatic arthritis, resembling the dysbiosis seen in inflammatory bowel disease, that there's dysbiosis that causes breakdown of the gut epithelial and vascular barriers in patients with AS. Again, like it was shown by Costello, Dr. Reveille showing that fecal microbiota shows specific studies, show specific dysbiosis in spondyloarthritis. Matt Stoll at UAB was able to show that there's differences in young patients versus older patients with spondyloarthritis in their gut microbiome. And Manasson now actually was able to show perturbations in the gut microbiota in patients with reactive arthritis or post-infectious spondyloarthritis. Then finally, we're dealing with the so-called mechanical or trauma triggering of spondyloarthritis, where we get a sequence of events giving rise to osteitis and enthesitis. And enthesis, of course, being where the tendon or ligament attaches to the bone. That's called the enthesis, okay? And that's fibrocartilage. And it gives rise to bone resorption, bone remodeling, and ultimately new bone formation and ankylosis. That's pretty well illustrated by, if you look at the Achilles tendon on this particular individual. And Dennis McGonigal in Leeds in the UK very nicely showed that the synovium and the enthesis are closely related. But stressing of this synovial enthesial complex, where the two interface, triggers the innate immune response, which dictates the clinical expression of disease, and that the primary basis for the pathogenesis of spondyloarthritis could be biomechanical rather than autoimmune, whether or not this represents an autoinflammatory disease. Looked at another way, this is some work that was done subsequently by Dr. Sherlock and published in Nature Medicine in 2012. This was a truly groundbreaking work because they actually were able to go into that spot, the enthesis where the tendon is attaching to the bone, and they found white blood cells in there. We're seeing that white blood cell there. White blood cells that express proteins on their surface called receptors that are very specifically labeled that ultimately will trigger an immune response that's associated with osteoproliferation, inflammation, and bone loss mediated by tumor necrosis factor, giving rise to the ankylosis and bone fusion that we see in spondyloarthritis. So we really see that there are a variety of different triggers out there. Reactive arthritis used to be called Reiter syndrome. I'll show you why that's a dated name. The clinical picture is preceding gastroenteritis or venereal infection. You see the conjunctivitis there, the swollen joint, and the characteristic skin rash called pterydermia, sausage digit, and again, more keratoderm blenachrum. That then causes urethritis or cervicitis, conjunctivitis, or arthritis, giving rise to the picture that we have associated with reactive arthritis. We don't know that reactive arthritis was first actually described in America. This is Dr. Isaac Center, who was a physician in the American Revolutionary War, where he described reactive arthritis following dysentery occurring in the setting of the unsuccessful campaign of Generals Philip Schuyler and Benedict Arnold before he crossed over to the British to capture Quebec in 1775. They had a massive diarrhea epidemic, and Dr. Center set up a field hospital to take care of the men who were too weak to proceed, and found that a lot of these actually suffered from rheumatism, including one patient who had the most violent rheumatism I ever saw, not able to help himself any more than a newborn infant. Every joint in his extremities inflexible and swelled to an enormous size. Brodie, of course, described this 100 years before Ryder did. Dr. Benjamin Brodie described a series of patients with classic reactive arthritis. We never called it Brodie's syndrome, however. He never got the credit, but he gave a much better description than Hans Ryder ever did. Dr. Brodie never joined the Nazi Party, of which Dr. Ryder was a prominent member. Now, we know that there are prominent bugs that are associated with reactive arthritis, most specifically in the so-called endemic reactive arthritis, chlamydia, but also in the post-dysenteric or gastrointestinal triggered reactive arthritis, Salmonella, Shigella, in Europe, Yersinia, and Campylobacter, and others that are, let's just say, a bit more questionable, have not been so well documented. Well, then we get to the Klebsiella story. This is one that is painful for me, but because there have been over 200 publications that have come looking at this. So many people are bitter about this because this has basically represented massive waste of time of so many people. But it started with Ebringer and his colleagues reporting an increased fecal carriage of Klebsiella in patients with active disease, which in a subsequent paper correlated with the sedimentation rate and the C-reactive protein levels. That was back in 77, 78. Seeger, the following year, reported that B27 positive patients have a lower in vitro lymphocyte response to Klebsiella. Ebringer then reported cross-reactivity going on there. Gexey found a modification by a certain Klebsiella soluble cell wall factor with HLA-B27, which he suggested to be a plasmid that he thought was associated with disease. That led Dr. Ebringer to propose a cross-tolerance hypothesis. And finally, in 1987, Olson et al. At Stanford found homology of amino acid between B27 and the Klebsiella pneumonia nitrogenase response in patients with AS. And he was very excited because he found patients with AS had antibodies to this particular protein that was shared between Klebsiella and patients and the HLA-B27 molecule. Well, guess what? A whole bunch of other groups could not confirm the fecal carriage of Klebsiella. The lower in vitro lymphocyte responses to Klebsiella antigens likewise could not be confirmed. The modification of the Klebsiella K43 derived cell wall factor was not confirmed by several other groups that looked at this, and they could not find any plasmid that was associated, which is only hypothesized in the first place. The antibodies to that homologous region shared by Klebsiella nitrogenase and B27, likewise not confirmed by a whole bunch of groups. Instead, they found that patients who have AS have IgA antibodies to a whole bunch of different intestinal bacteria, regardless of if they're B27 positive or B27 negative. And finally, where they did, in a few studies that found some antibodies to Klebsiella, found no association with AS, with disease activity, or with cross-reactivity of B27. So this has largely been discarded, but Dr. Ebringer is still holding out on this, as are one or two splinter groups, but no one believes this anymore. In the SOAS study, we have found, moving on to treatment, that the spectrum of disease has changed over the years, that we see much less non-steroidal anti-inflammatory drug usage. If we look, patients enrolled between 2002 and 6, 7 and 14, and 2015 to 19. Less NSAID use, less anti-TNF usage. I'm sorry, more anti-TNF usage, and less non-biologic DMARD usage, such as sulfasalazine and methotrexate. Much less as opposed to the earlier phase of the study, as opposed to the later stage of the study. So basically, the treatment trends in spondyloarthritis have changed a great deal. We also find that AS is different from ethnic group to ethnic group. Looking at the SOAS study, that Blacks, even though AS is much less common in Blacks, have by far the most severe disease, as evidenced by greater disease activity, greater functional impairment, and much, much worse radiographs looking at the MSAS. So this is a very racist disease, and apparently the disease, Black lives only matter insofar that they can be more severely affected. So moving on to obviously a hot topic right now. I don't know if you said, but more and more people who attended that rally last Saturday are now, Chris Christie is now come down with COVID, who was present there. So apparently everyone that our president's come into contact with virtually in the past week has now come down with COVID. This is a big, big problem. It is not going away. It's not forecast to go away anytime in the near future. And so the issue is, what about patients with spondyloarthritis? This is the most recent study just published last week, looking at the impact of the COVID-19 pandemic on the disease course in patients with inflammatory rheumatic disease. This is a study from Switzerland. What they found was that patients were seeing their rheumatologist much less frequently face-to-face. Instead, remote assessments increased by 129%. That drug compliance, non-compliance rather, went up, but that the proportion of people who had flares in their disease because of this actually remained stable. There's no mean increase in the BOTH Ankylosing Spondylitis Disease Activity Index, the Rheumatic Disease Activity Index. And so that this short interruption that between the patient rheumatology interactions doesn't appear to have caused any major problems. Jean Liu, who is now at Boston University, did a survey of patients at the University of California, San Francisco, and found that patients with axial spondyloarthritis who had reported much higher levels of stress and anxiety had significantly higher disease activity levels, although with a difference below clinical importance. And so that trajectory is further being examined. Reveille et al., that was published back in June, looked at the impact of home confinement during the COVID-19 pandemic on medication use and disease activity in spondyloarthritis patients. This is published in Arthritis Rheumatology, and found that home confinement linked to COVID-19 pandemic is associated with worsening of the disease and reduction or suspension of medication intake in particular patients in French spondyloarthritis patient. It has considerable clinical implications, given that home confinement is likely to recur in the future. Patients need to be educated about the current evidence of NSAIDs and other drugs and ways to stay physically active at home. I can tell you, here in Houston, Texas, 80% of my patients are face-to-face visits, okay? And I got news for you. The overwhelming majority of my patients have gained a lot of weight over the past 6 months. So this is an issue. This is an important issue. If we look at a variety of different studies that have looked at COVID-19 and spondyloarthritis, we found that COVID-19, this is by Sanchez Piedra et al., the COVID in Spain, the COVID-19 course mortality in patients with rheumatic diseases treated with biologic DMARDs, i.e. biologic drugs, did not differ. The COVID-19 course mortality did not differ from the general population, although the hospitalization rate was slightly higher. That Gianfrancesco et al., looking at the COVID-19 Rheumatology Alliance, found the glucocorticoid exposure of greater than 10 milligrams a day is associated with higher odds of hospitalization, and with anti-TNF, decreased odds of hospitalization in patients with rheumatic disease. Neither exposure to DMARDs nor NSAIDs were associated with increased odds of hospitalization. Looking at an early case series from New York City by Haberman et al., found that the baseline use of biologic was not associated with worse COVID-19 outcomes, that looking at coronavirus 19 and non-steroidal anti-inflammatory drugs, and Dr. Giotto was really fervent on this, that they said that patients with chronic inflammatory arthritis need not discontinue their NSAIDs, that stuff about the cytokine storm was basically over-reported and not relevant. Monti et al. Found that the patients with chronic arthritis treated with biologic or traditional DMARDs do not seem to be at increased risk for respiratory or life-threatening complications. And finally, De Silva et al. Found that patients with rheumatic disease and COVID-19 infection may be more likely to require mechanical ventilation, but had similar clinical features and hospitalization rates as those without rheumatic disease. And of course, the rheumatic disease they're talking about here wasn't ankylosing spondylitis, it was mainly lupus and rheumatoid arthritis. Dr. Rosenbaum, looking at this membership, in a survey of this membership, found that 16% of the patients, this was published in the Annals of Rheumatic Disease, had reduced or stopped their medications. Most, however, thank goodness, have not. And I hope I showed you that's important. And finally, in the paper that was just accepted, that basically being B27 positive, if you're B27 positive, you have natural protection against HIV and hepatitis C, and to a lesser extent influenza. But there didn't appear to be any influence of being B27 positive and COVID susceptibility and severity. These are two studies that you all greatly contributed to, and we're very, very grateful for that. So in AS, we try to reduce signs and symptoms, improve function, improve structural damage, quality of life associated with factors. There's a whole paradigm we've been using for years of exercise, NSAIDs. Depending if they have peripheral axial disease, we'll use sulfasalazine. And of course, now a variety of biologics. This is too much to go into in great detail, but this slide is very, very important. Basically, we give non-steroidals first. These are the 2019 update of the ACR, Spondylitis Association of America, Spartan recommendations for treatment of ankylosing spondylitis and non-radiographic disease. Again, for active disease, full dose NSAIDs and physical therapy are highly recommended. We advise against systemic glucocorticoids. We only give DMARDs like methotrexate, sulfasalazine, and those with arthritis. For isolated sacroiliitis or enthesitis, we'll try local glucocorticoid injections, but not in the Achilles tendon. If the NSAIDs don't work, we of course recommend going to a TNF blocker. If that doesn't work, we recommend to go to an IL-17 blocker or another TNF blocker. There's no TNF blocker that's any better than the other. And if there are on TNF blockers and still have active disease, we do not feel that adding methotrexate helps anything. And of course, if they have recurrent uveitis or AS, we refer the TNF monoclonals over etanercept or other biologics. So again, these are the current guidelines. These slides are being downloaded and you can study them more. But we have continued to refine this as new drugs come out. Physiotherapy is very, very important. All our patients with spondyloarthritis get a physical therapy consult. There are a whole bunch of drugs that are now out there, cost a lot of money, but only a few of them actually work in axial spondyloarthritis. Of course, we know about tumor necrosis factors. We know about IL-17 blockers. There's a whole bunch of them that are out there now. They work very well. They have different efficacy in rheumatoid arthritis, Crohn's disease, and the like, where different drugs are available that I'm not going to go into here. So TNF blockers and IL-17 blockers are currently out there. We know that patients who are most likely to respond to TNF blockers are those who have short disease duration, are younger, and have elevated inflammatory markers, as opposed to those who have longer disease duration and normal inflammatory markers, much less chance of responding. That in psoriatic arthritis, there's likewise a bunch of medications that are out there, as we can see here. I see that the time is getting short, so I really want to move a little faster. NSAIDs, of course, work very well. You need to be taking full dose NSAIDs you're seeing here to get the full effect, and we highly recommend this if you can tolerate that. That NSAIDs themselves have been shown perhaps to slow down radiographic aggression. This is the MSAS and those taking full dose regular NSAIDs as opposed to when they felt like it. You see there's a big difference. That, again, I don't have time to go into this, but the treatment of psoriatic arthritis depends on which manifestation of the disease is most prominent, whether it be peripheral arthritis, axial disease, enthesitis, dactylitis, skin, or nail involvement. And that TNF therapy works for, and has been approved a number for non-radiographic axial spondyloarthritis. I already showed you that. For eye involvement, we recommend treatment by an ophthalmologist, topical glucocorticoids. The monoclonals are highly recommended over etanercept. For cardiac disease, we don't have any specific treatment that we know of yet. This happens over an extended period of time, and it should be monitored at least clinically. It occurs over time in up to 1/3 of patients with spondyloarthritis. Neurologic disease are most importantly spinal fracture. So you really have to keep on top of bone mass. And so we do recommend a screening for osteopenia and osteoporosis, because up to 40% of patients with spondyloarthritis will have osteopenia or osteoporosis. And spinal fracture here is absolutely devastating with a very high mortality. And the wedge osteotomy for AS, where correction of fused spine, is only recommended in those with severe impairment due to disease, because there is a significant mortality associated therewith. I better stop right here. That's a picture of a snake who has ankylosing spondylitis. You might imagine how devastating that would be for this poor snake. He actually died when someone slammed the door on him because he couldn't move fast enough because of his fused spine. And I'll let it go there.
Q&A session. So the first question was about psoriatic arthritis. Treatment, just more information on it. So I think that's a great segue, as you were just saying that you had more information to share about that. So maybe we can get started with that question.
Yes, well, certainly the treatment of the psoriatic arthritis has to do with what manifestation that has to do with what is predominant. If it's the spinal disease, if it's the peripheral disease, the skin disease, or if it's the enthesitis, because there are certain medications which work well for psoriatic arthritis that don't work very well in spondyloarthritis, like Otezla, Premolast. That works very well for the skin, fairly well for the joint, doesn't do anything in ankylosing spondylitis. Blocking interleukin 23, whether you're going to do ustekinumab or risankizumab or whatever, or guselkumab, it doesn't work in AS, but it works very well in psoriasis and psoriatic arthritis, and is recommended. So there are some differences, and these differences are predicted, by the way, by the genes. That interleukin 23A is a gene that's associated with psoriasis, but not with AS. It's not one of those shared genes. So actually the genes do predict treatment response.
Thank you very, very much. Okay, next question. How often should patients with spondyloarthritis have x-rays to see progression of the disease?
Very, very good question. Certainly no more commonly than every 2 years. That the likelihood of seeing a change over a 2-year period is about 7%. When the SOA study was more active and we were actively NIH funded, I was getting x-rays from those patients every 2 years, and most didn't really change. And now what we do is if a person has had a period of disease activity, or with my patients, as those who are on this call who are my patients well know, I do measurements at virtually every visit, and of the spine, of how well the spine moves, the neck moves, and the like. If I see a deterioration, significant deterioration in the measurements, I will go ahead and get x-rays because our data do show that deterioration in those measurements of spinal mobility do predict radiographic worsening. So, but I certainly don't get x-rays any more frequently than every 2 years, unless, like I said, I'd see a deterioration in the measurements. And a lot of my patients, if we're completely stable, I go out further than that now.
Wonderful, thank you. Next question, does the disease tend to be less severe in women? Does it manifest more in different locations like upper back or neck in women?
Very good. I actually had a slide in it, and I'm sorry I took it out. I was, but AS is unfair in women. Women are unfairly affected because even though they're less likely to, that first of all, ankylosing spondylitis, meaning modified New York criteria, is more common in men. That women have an equal, if not greater, frequency of axial spondyloarthritis. That women are most likely to stay in the category of axial spondyloarthritis, non-radiographic, and not progress to radiographic AS. And of course, I will tell you that outside of rheumatology, and even in rheumatology, that docs don't know what non-radiographic axial spondyloarthritis are. So many of these women get called fibromyalgia or the like, and just plain aren't treated. That women have equal levels of disease activity, that as far as their subjectively, more joint stiffness, pain, and the like. That women are equally, if not greater, have a greater functional impairment than men with the disease. That women have less spinal involvement, but more peripheral joint involvement, and that women are less likely to respond to biologic agents than do men. So it's a very, very sexist disease.
I see. Thank you. And you touched on peripheral. There was a question just to clarify a bit about what peripheral spondylitis is. Could we just quickly touch on that again?
So peripheral spondylitis is either having dactylitis, which is like a sausage-like swelling of a finger or toe, or having peripheral arthritis, like swelling of a knee or ankle, or having enthesitis, like a swollen Achilles tendon or the like. Having one of those, and having other criteria associated with spondyloarthritis, like uveitis or elevated C-reactive protein or HLA-B27 positivity or the like. So having any one of those three, dactylitis, enthesitis, and peripheral arthritis, and other features common to spondyloarthritis that we've already talked about, inflammatory bowel disease, psoriasis, B27 positivity, elevated inflammatory markers, and the like.
Thank you. Next question is, this person has had AS for 47 years, and it is now affecting their lungs, causing them to get very out of breath easily. Do you have any suggestions on how to deal with this?
Well, now that particular symptom, being out of breath, can come from either lung involvement or heart involvement. The lung involvement, there is a scarring at the top of the lungs called the apices, so called apical fibrosis. It's actually quite uncommon. I've only seen a handful of patients in my entire career that had that. But I have seen more frequent heart involvement. The most common thing is going to be damage to the aortic valve. But you can also see heart conduction defects. And they may occur in a patient even without spondylitis. I take care of two different professors, oops, I shouldn't have said that, at a prominent medical center nearby, I'll just not get any more specific, who are B27 positive, have other features of spondyloarthritis, have ascending aortic aneurysms, aneurysms in the aorta where it's coming out of the heart. I have seen aortic insufficiency. And when these things aren't treated, especially when you have a valve problem or a heart conduction problem, they can cause the heart not to pump so well. And you can have severe shortness of breath associated therewith. So you have to define if this shortness of breath is coming from the lung or from the heart, all of which can be related to spondyloarthritis.
Thank you. Next question, how does one know when a patient has to move from an over-the-counter drug such as Advil to a prescription drug or a biologic specifically? Also, what's the evidence that a biologic heals or potentially slows down the disease as opposed to just kind of treating symptoms?
Okay. We were actually the first to publish that using TNF blockers slows down slows down radiographic progression. There's now been several other groups that have shown the same. So anti-TNF blockers does indeed slow down radiographic progression. The data are just coming to the fore now about the IL-17 blockers in that regard. We know that is one feature. And it's an important feature to know that uncontrolled inflammation gives rise to fatty replacement in the marrow, which in turn gives rise to a developing syndesmophyte. It's called backfill on an X-ray or on MRI rather. So I think that's very well established. The data that that using non-steroidal anti-inflammatory drugs slows radiographic progression comes from initially from I will say rather flawed but decent study by Wanders et al. Published in 2005. A subsequent study by Des Podivny showed that only the higher doses seem to make an effect in that regard. And now those two studies both use celecoxib. Another study that Joachim Sieper did using diclofenac showed, if anything, that people who use diclofenac actually did worse. So that may not be common to all nonsteroidals. This is an area that needs more study, obviously.
Thank you.
And did I answer the whole question, or did I miss part of that?
I think you did. I think you did. Thank you. Okay, the next is kind of a two-part question. So what about the prevalence of HLA-B27 in African Americans? And then you mentioned that the disease impacts African Americans more severely. Can you elaborate on that as well? If you think it's due to environmental factors or because, delayed treatment, what might that cause?
So in the paper that we published, we actually showed that the disease duration in the African Americans was less. So it was not a question of later diagnosis. The disease duration was less in the African Americans. I've already told you that B27 positivity has nothing to do with radiographic severity, or really severity in general of the disease, except for the presence of uveitis. And blacks have a lower frequency. Only about 60% of blacks who have AS will be B27 positive. We published that in our study. Dr. Mohammed Khan published that one feature, not the other features, published that way back in 1978. So we've known that for a long time. That HLA-B27 is very rare, it's rather rare in Africa, and there is a subtype of B27 that's found in Africa called B2703. It's unique to West Africa. That is actually not associated with AS. That even though I've seen AS patients who were black who were B2703 positive. But it's not associated to the extent that the other B27 subtypes are. That the B27 in African Americans is 1.1%. It's much more rare in Africa, and that probably represents white genetic admixture. If you look, there's a lot of publications on this, but African Americans are an admixed group compared to Africans per se. There's white genetic admixture, there's some Amerindian genetic admixture, there's even some Latino genetic admixture, depending on what part of the country you're looking at. But B27 is much less frequent. The disease is much less frequent. We showed that in the NHANES, but that when they get it severely. If I were to hazard a guess why that is, the only thing our study showed that could in any way explain this was that African Americans are much less likely to be taking TNF blockers or other biologics. And so perhaps there was an issue, even though it was not an issue of timely diagnosis, it was an issue of access to healthcare.
I see, thank you. And then just to clarify, it was 60% of African Americans with AS will be positive for HLA? Oh, that was AS.
AS who are black have B27.
Got it. Thank you very much. That was, I think, really helpful information. Okay, so next question. A male who is 60 years old, recently diagnosed with spondylitis, tried Advil for 3 months, but it caused stomach irritation. Now the recommendation is to try biologic. The question is that they're nervous about compromising their immune system with COVID. What would you say to that?
I hope I made it clear from that slide that I showed you that using biologics is not associated with increased susceptibility or severity of COVID. That has been shown in France, in Spain, in 2 sites in the United States, in Brazil. I don't know how many more times, and in Switzerland. I don't know how many more countries we can show this that all show the same thing. So no, there's not an issue here. Take it, for heaven's sakes. You know, just like that fellow on Fox News said, wear the damn mask. I mean, this is an issue.
Thank you.
You know, don't worry. Take your medications, for heaven's sakes.
Got it.
Same thing for anti-inflammatory drugs. That early data out of France, that 5 cases out of France, that was a red herring. That is not what has been seen around the rest of the world. And
right, the ibuprofen. This is about the ibuprofen. Thank you. Okay, the next question is a question about stem cell. Is there any progress being made in the treatment of spondyloarthritis with stem cells? You know, could they be effective in treating chronic low back pain, or degenerative osteoarthritis, or spondyloarthritis?
Yeah,
anything on that?
I deal with this a lot because the 2 big companies that do this is one in Mexico City that actually was in Houston before the FDA literally chased them out of the country. They went to Mexico to avoid legal issues. Then there's another group in the Cayman Islands. If we also you can deposit your bank account. There is simply no evidence that stem cells work in spondyloarthritis. Some of the early evidence actually showed that it triggered the disease. There is no evidence that it works in any kind of arthritis. There's no evidence that it works in osteoarthritis. In fact, the American College of Rheumatology strongly recommends against stem cell transplants in knee osteoarthritis. And there's a good reason for that, because stem cells, stem cells are smart, but they're not that smart, okay? With knee osteoarthritis or with spondylitis, it's not just one kind of cell that's deficient. It's a whole bunch of other cells that are in play, different populations of white blood cells, cartilage cells, bone cells, enthesitis cells. And those stem cells are going to be pretty darn smart to know where and when to differentiate it in what tissue. It doesn't work that way.
Thank you. How does the gut microbiome affect people with ulcerative colitis?
Again, what's been shown there is that the patients with ulcerative colitis and Crohn's disease have a different microbiome than do normals. To what extent that is, we know that, for example, that people who are B27 positive have a different microbiome than those who are B27 negative. And the extent to which that microbiome is influenced, genetic issues, isn't particularly clear. That if you look, certainly with Crohn's disease, but secondarily with ulcerative colitis, I've mentioned before about this idea of the bugs getting across the intestinal lining, or even through the intestinal cells. And there are genes that like ATG16L1 and IRGM that make proteins that are very important in eliminating those bacteria before they can get into the circulation. And that the genes that are associated with inflammatory bowel disease, especially Crohn's disease, don't function quite as well to make this happen. So it's thought that there may be some access of these bugs or the proteins associated with the bugs to the systemic circulation is giving rise to this immune response. All of which is being worked out, but we know at least that the patients with ulcerative colitis and Crohn's disease have a different microbiome than do normals.
Thank you. I have a couple of COVID-19 related questions I'm going to put together. So the first is, if I'm HLA-27 positive and have SPA, does that mean that my immune system is on hyperdrive? And if so, does that mean my risk of contracting COVID-19 or maybe of having a more severe outcome is lowered?
Well, we already published the fact that actually this paper is in press. Okay, it's in journal, it could be in the Dermatology, but we showed, looking at the SAA population, that there's one other study from Europe that showed the same thing. There's no association of B27 severity. B27 positivity and susceptibility to or severity of COVID. Okay, they're walking in different directions. So that is not an issue.
Even in terms of offering increased protection, I think was the question.
B27 does not offer protection against COVID, nor does AS.
Okay.
there was a whole bunch of studies. Every study that's been published has shown there's no increased mortality. There was one study that showed that patients with rheumatic disease, but this was mainly lupus and rheumatoid arthritis, had a higher likelihood of ending up on respirators if they did get hospitalized. But the mortality data, the hospitalization data, none of that showed any difference between those who did and did not have either AS or other rheumatic disease.
So no impact either way, positive or negative, it's looking like.
What?
No impact either way, either positive or negative.
No impact, no impact, no
Got
impact,
it.
no impact.
No impact. Okay. The next question is about a potential vaccine. So it's a hypothetical question, of course, but understanding that there is no approved vaccine, COVID vaccine yet available, once one does become available, do we know yet whether there might be any special considerations for those with spondyloarthritis that we should be aware of with respect to taking the vaccine? And also particularly to those on a biologic.
Right. Given that, well, first of all, there are overall recommendations regarding vaccines, and is it a live vaccine or a killed vaccine? We do not recommend live vaccines in patient biologics. Whether or not there's good science behind that, it's not clear, but that's just a simple recommendation of the American College of Rheumatology, the European League Against Rheumatism, and the like, that we prefer patient biologics get killed vaccines, not live vaccines. Okay, that's one statement right there. Secondly, patients with spondyloarthritis get vaccines all the time. That's patients on biologics, okay? If you're not on biologics, there is simply no evidence that getting a vaccine it has higher side effects if you happen to have spondyloarthritis. And of course, with the COVID vaccine coming out, personally, I'm a little skeptical because this is a rather smart virus that tends to change its code a lot, just like the HIV does. And look, we've been looking for an HIV vaccine for what, 30 years? Nonetheless, there are trials coming out. We will probably have a vaccine. I hope it's developed in a systematic way, not rushed by political concerns, so that we have a vaccine that we know is one, safe, and two, effective. All the projections are, before we get to the point where that is going to be available, be well into next year, if not later.
Thank you. Next question is, this person was taking Mobic for AS and now they have kidney disease, unfortunately. What can they take that won't damage the kidneys further?
Good question, good question. Okay, because I wrestle with this all the time. First of all, the kidney problems associated with non-steroidals is dose dependent. So perhaps another anti-inflammatory in a lower dose would be tried. I remember I gave medical grand rounds at the Methodist Hospital 2 years ago, and a big fight broke out between the nephrologists over this very question. So we know that this problem is in part dose dependent. So a lower dose would be tried. If not, it might be necessary to go right to a biologic and to skip the NSAID. There is the occasional patient who, for one reason or another, can't take a biologic and is, now we're way outside of guidelines right here. Can't take NSAIDs and can't take it for one reason or another, take a biologic, and who I will give low-dose prednisone to. But really, that is not recommended by the American College of Rheumatology. But in that select circumstance where NSAIDs cannot be given, and for some reason the patient doesn't have access to a biologic, I will try that. I'm not happy about it.
Thank you.
And as you know, although the use of a steroid called dexamethasone has been shown to be literally a lifesaver in those COVID patients who are requiring a ventilation, that's the good news. The bad news is, however, in your patient with mild COVID or early COVID, taking corticosteroids actually is not a good thing. And that it actually increases your risk for disease progression and in COVID. It's just that, with a lot of these treatments of COVID, it's all a matter of timing. That these medications introduced at one stage of the disease may not work or be harmful, or is introduced at another phase of the disease, may be life-saving.
Wow, thank you. Next question is, I have psoriatic arthritis and AS. He has had x-rays and MRIs and results came back not what they were expecting or wanted to hear. They're wondering what the pain is all about. It seems like that not much has been showing. It's how can I be diagnosed through my primary rheumatologist doctors, but MRI readings come back not showing or validating my pain. Any advice? They're hoping that the pain management specialist will kind of prove the situation is more real than what, yeah.
Ultrasound has been very helpful. I do have some patients who don't come to me with a lot of joint pain, not a lot of swelling, where under ultrasound, we have actually seen changes in the tendons where they stick onto the bones, the epiphyses, that were entirely compatible with psoriatic arthritis. Again, this is in a patient having symptoms, because you can see some of those changes in patients with no symptoms also. But when I get a patient with symptoms and corroboration by an ultrasound, that helps me in guiding treatment. MRI can sometimes show inflammation that may not be apparent on that clinic visit. But that's sometimes hard to get insurance companies to pay for an MRI of the hands or the feet or whatever. Well, no, not really, actually. I usually don't have an issue getting it my patients. But MRI can be another way of helping to document inflammation. And if the MRI or ultrasound is negative, you need to be looking for other causes of the joint pain in psoriatic arthritis. And of course, the clinical evaluation, negative.
The clinical evaluation, got it.
Because that all starts with the clinical evaluation.
Right, so, but is it possible for someone to have normal MRI, normal X-ray, and also have spondyloarthritis?
And have psoriatic arthritis,
Arthritis,
without physical findings, without imaging findings, without ultrasound findings, it would be hard to establish that diagnosis.
Okay. So ultrasound might be helpful. Got it, thank you. Is CBD helpful for AS?
We actually, I've done a lot of work in this area. CBD, CBD oil given under the tongue is the only way it should be used, okay? The cream, we don't know if it works or not. There's no good data. And if you take it by mouth, like with gummies, you don't know what you're absorbing because everyone's intestinal tract acts differently. But the drops under the tongue are helpful. To some people, it's not FDA approved, by the way. It's not FDA approved in dealing with pain. And God help you if you happen to live in Nebraska, I think it's South Dakota and Kansas, because it's completely against the law. Right. The 3 states is still against the law. It's illegal in the rest of the states. It's not. It's still at the level of the federal law illegal, but obviously being legal in the state, they're not going to enforce that. If you are, however, a federal employee, just know that if you're taking CBD oil, it's going to give you a positive blood test for marijuana or THC, even though you aren't taking that. That's one problem you have to keep in mind. So if you are on that, you need to let your employer know so that if you do go get a urine drug test, you don't get nailed. That said, again, it's not FDA approved. The only thing CBD is approved for is for pediatric seizures, certain pediatric seizures. But there are data that suggest that it does help a patient deal with the pain better. It has a calming effect, and you should have a certificate of quality or a stamp of quality on that product, because a lot of CBD is being made in mom and pop stores right now, and you don't know what the devil you're getting, okay, because it's not FDA regulated. But you want to have that certificate of quality, which means that it's been assayed by an outside lab, and what you're getting has what it says that you're buying.
Are really helpful tips. Thank you. Next question is, are there any specific foods that are shown or that may potentially reduce inflammation in this disease? Anti-inflammatory kind of.
I'm a big diet person, okay? So the short answer is no. I'm a big diet person because we're digging our graves with our forks. Obesity is rampant in this country. Fat people do not respond as well to anti-TNFs. Fat people have adipocytes that contain all these pro-inflammatory chemicals that make dealing with COVID a real problem. Obesity is a major risk factor for bad outcome in COVID. It's also a risk factor of bad outcome in lesser TNF responsiveness in patients with spondyloarthritis. So I'm a big dietary person.
Mm-hmm.
I think there are the intermittent fasting is a really fantastic as far as helping you lose weight. And of course, the keto diet, there's a lot of good data on that. These are all things that I discuss with all of my patients because it's very, very important. And I want you to think about this. If you're more slender, you have less of those adipokines floating around that are making you inflammatory, that are very pro-inflammatory. So a pro-inflammatory diet is when you're preferentially burning your fat and reducing the size of those fat cells. So that's the most important thing I could really tell you.
So it sounds like losing extra weight and being more slim is really helpful in better outcomes. And got it. Thank you.
I have to tell you, I'm a fanatic on intermittent fasting. I've lost 25 pounds since Christmas, and I'm down to my college waistline. Of course, I exercise in the morning while I'm fasting, and I can tell you, boy, it's improved the quality of my life and my own pain.
Wow. Thank you for sharing that. The next question is about pregnancy. Do symptoms of either a non-radiographic exSPA or other forms of SPA become more severe during pregnancy?
The studies have been rather contradictory. It's certainly not like rheumatoid arthritis where disease symptoms get significantly improved during pregnancy. Patients with rheumatoid arthritis actually like being pregnant because they're going through a period of relative disease inactivity as a rule. Patients with lupus frequently have major flares and bad outcomes when they're pregnant, especially if they have renal disease. So we don't have the clean-cut story that we have with lupus or rheumatoid arthritis. It's a bit more inconsistent, and it's not a contraindication to pregnancy.
Thank you. And one last question, because we're about 2 minutes out. Can you clarify if trauma can actually set off or trigger spondyloarthritis, injury or fall or?
Yeah, I was in a deposition last Monday afternoon over that question. There are data from McGonigal et al. that trauma can trigger a disease flare. Whether it actually triggers the disease per se is much, much less clear. And trauma, especially mechanical trauma, because we showed you, and there's some really gruesome, I call them gruesome, but involving mice where they take mice with spondyloarthritis and they suspend them by their tails so that their back legs aren't hitting the ground. And they find that there's no disease progression in those legs, as opposed to the front legs. So they're clearly in pushing a flare. There's a role in actually triggering disease. It's just not clear.
Got it. Okay. Well, thank you so much, Dr. Reveille, for that informative both Q&A and the presentation, of course.